all. We'll be starting. First of all, thank you to the academic cell of ASG Hospital, Dr. Kaushik, Dr. Ganesh, Dr. Mayank, and Dr. Atul for getting this session together. I welcome our esteemed speaker and panelists. I'll be co-moderating with Dr. Paras. I myself am Dr. Shreya Nayak, a retina specialist working in ASG Hospital, Meerut. Starting with our speaker, Professor Dr. Şengül Özdek. She is an esteemed and a very well-known ophthalmologist. She has been an assistant professor since 2004 in Gazi University and at present is a full professor in Gazi University. She has done her clinical fellowship in innumerable places, esteemed places also. She is a distinguished leader in the field of ophthalmology, specifically ROP and pediatric retina. Her expertise, particularly in retinal diseases, has earned her international recognition, including prestigious awards like the EVRS Ambassador Award, ASRS Honor Award, AO Awards. Over 140 international and 130 national journal articles to her name. We welcome you, Professor Şengül.
Thank you. I'm happy to be here.
Same here, ma'am. Next in our panelist, we have Dr. Subhadra Jalali, ma'am. Every ophthalmologist in India knows her name. She's a faculty at LVPI since 1993, director of the Newborn Eye Alliance at LVPI, member on the National Task Force on ROP Government of India, expert advisor on ROP to the governments of Bangladesh and Philippines. She also has innumerable awards. I could fit just these many in these slides. International Talent Search Award, the AAO Achievement Award, APAO Achievement Award, and many more. She has over 750 presentations, 180 publications in national and international journals. We welcome you again, ma'am. Over to you, Dr. Paras.
Hello, good evening to all. So along with Dr. Subhadra ma'am, we have in our panelists Dr. Maria Ann Martinez ma'am, who, as we all know, is a very renowned ophthalmologist who has had very excellent work in ROP. She has been an assistant professor and retina surgeon at Luis Sanchez Bulnes Hospital since 2008. She is a clinical professor in pediatric retina at National Autonomous University of Mexico and also has a private practice at Eye Disease Clinic Toluca. She's a coordinator of 7 multi-center studies of the anti-angiogenic therapy in ROPs and is a founder and president of Retina Telemedicine. She has been awarded with multiple prestigious awards like Tyson Award, Honor Award, Senior Honor Achievement Awards, and has over 75 publications. Her work in ROP is a milestone to be achieved by all the new retina surgeons, and welcome to you, ma'am. Along with ma'am, we have Dr. Susana Texera. She has done her residency in ophthalmology from Lisbon, and currently since 2015 she has collaborated the ROP section of treatment and screening at Hospital Fernando Fonseca. Since 2006, she has been using anti-angiogenic therapy for the neovascular disease in the eye like diabetic retinopathy and ROP. And ma'am has been the first in the world to use bevacizumab injection for ROP and the neovascularization associated with it. And she was the first to publish the paper regarding it. We welcome you, ma'am, and we are all, enlightened to listen from all the faculties, from all the renowned faculties. And without further ado, let's start the session today. I hope everyone has their notepads in hand because there's a lot to learn today.
Thank you. Should we start?
Sure, ma'am. We are waiting for it.
Okay, perfect. Can you see my presentation?
Yes, ma'am, it's visible to us. Thank you.
Thank you. First of all, I would like to thank to my dear friend Atul for inviting me to talk here, to give the chance to talk about ROP today. And I would like to thank to my friends to join me, Susanna, Mariana, Subhadra, all of them to join me for the discussion. So since Atul asked me to start from very basics to advanced ROP, so I will try to cover everything. But of course, in 1 hour, it will not be too deep, but we will discuss at the end. I think that discussion will add some more to the missing parts. So you know that ROP is a vasoproliferative retinal disease in preterm babies, and it develops in immature, non-vascularized retina. And you know that vasculogenesis starts in retina at 16th week of gestation, and it reaches to nasal aura by 32nd week, and to the temporal aura by 40th week. And this schema is very nice one, you know, I like it very much, and it summarizes almost everything for ROP, like especially the pathogenesis part. You know, in the intrauterine life is relatively hypoxic environment, and we have normal oxygen and VEGF levels. And when the baby is prematurely born, then we have to give oxygen to keep the baby alive, and that oxygen levels lowers the VEGF levels, and we have the stoppage of the vascular growth at this stage. And by the 31st week or so, post-menstrual age, then the retinal cells in the avascular retina starts to mature, and the oxygen in the environment is not enough for them to supply, and then those avascular retina starts to secrete very high levels of VEGF, and it stimulates neovascularization. And at these stages, which is between 31st and the 42 weeks of postmenstrual age, we have the neovascularization and development of ROP. And when we see significant ROP, we have to treat at these stages. And after that, VEGF levels decrease and neovascularization stops, but fibrotic component becomes the predominant pathology and cause fractional retinal detachment. So this pathology was previously in 1950s was called as retrolental fibroplasia. Then a group of ophthalmologists came together to form the International Classification of ROP Committee, and their aim was to describe an internationally accepted, correct and common terminology for ROP. And the first committee published 2 papers, and I want to suggest reading of these papers by ROP committees for all the participants here, because these are very important papers and these are very important steps for to understand ROP. The first committee published 2 papers in 2080s, and the second committee published in 2005, and the last one was in 2021 with the most updated data. And I was one of the committee members in that the last one. And if you like to download the paper of the ICROP 3, you can scan this QR code. And I just want to summarize from the beginning. You know, in the first ICROP paper, the committee described the zones, stages, plus disease and extent of the disease. And as you all know very well, zone 1 was the area between around the optic nerve with a radius of from disc to macular distance, twice the distance of the disc to macular distance around the optic disc area. And the zone 2 was the donut-shaped area around the zone 1 with a radius of disc to nasal aura, and the third zone was the crescent-shaped area around that zone 2, which is in the temporal part. And when we just try to see it from the real montage picture of a baby, you see that this is zone 1, and this is zone 2, and the area remaining is the zone 3. And in ICROP, the second ICROP, which was ICROP revisited, they described zone 1 in a better way. They said that when you use a 28 diopter lens and when you place the nasal edge of the optic disc to the edge of the view, and the other edge shows you the zone 1. This was a good practical way of understanding zone 1. And when you place it to the real picture, it looks like this. And for the zones, we also have normally, if the borders are irregular, I mean the ridge is irregular, the most posterior part is accepted as the zone. But we also have some notches, you see like this, which is an incursion of the ROP lesion of 1 or 2 clock hours along the horizontal meridian into a more posterior zone than the remainder of the retinopathy. And when you have such a disease, it's not the same as, the prognosis and behavior is not the same as the ridge, which is homogeneously in zone 1, for example. That's why such notches should be indicated. And in the last ROP, which is the ROP 3, the committee introduced the term notch to describe such incursions, and this should be indicated like zone 1 secondary to notch. And another novelty by ROP 3 was the definition of posterior zone 2. Posterior zone 2 is a posterior disease, and it's not similar to the more peripheral disease. It may be more aggressive. That's why it's important to describe that area. And it was not clearly described before. And the description was done by ROP 3 committee as a region of 2 disc diameters peripheral to zone 1 border. So this will indicate potentially more worrisome disease than ROP in the more peripheral zone 2. So again, this dashed lines indicates the posterior zone 2. And again, when we just want to see it in this picture, we add 2 disc diameters anterior to zone 1, and now we have zone 2, posterior zone 2. When we look at the stages, we look at the border of the vascular avascular retina. And when we have just incomplete retinal vascularization, we indicate that. And then ROP develop, when ROP starts to develop, it starts with stage 1, 2, 3, 4, and 5. And when we have just incomplete retinal vascularizations, some people were saying that it was stage 0, some were saying that immature retina, no ROP, and in the last ROP 3, it was decided that it should be termed as incomplete retinal vascularization, and the zone and extent of the immature retina should be indicated also like in the other stages. When we have stage 1, you have only a demarcation line, which is a flat, thin, whitish, clear-cut demarcation between the vascular and avascular retina. And in these cases, we mostly observe it, if not in zone 1 with plus disease. And in stage 2, we have again a line, but now it has a little bit elevated. It's more elevated, a little bit. Third dimension is gained because neovascularization is more at this stage. And we usually observe, if not in zone 1 with plus disease, most of them regress spontaneously. And in stage 3, we have a very prominent neovascularization. It's now very extraretinal fibrovascular tissue growth, and it extends towards the vitreous. Sometimes we can have flat neovascularization, especially in aggressive ROP cases, which doesn't go into the vitreous. And in the last ROP committee, it was also accepted as stage 3 flat neovascularizations. And when you leave such lesion, it will progress, half of them will progress for sure, and half of them will regress spontaneously. So when we have a stage 3 disease, you should look at if there's a plus disease, or if it is zone 1, then you should decide on treat and observe things. I will come to that point later. So we can have different stages in different areas. For example, this part is zone 2, stage 2. This part is stage 3, more elevated. The more advanced stage should be accepted to indicate that eye, to the stage of that eye. And you can have mild, moderate, or very severe stage 3 cases. And for stage 4, we have now retinal detachment, the start of retinal detachment, which is subtotal retinal detachment. If it doesn't involve stage macula, it's stage 4A. If it involves the macula, it's called as stage 4B. And you should look at the temporal vascular arcades. If there's straightening, as you see here, straightening of the temporal vascular arcades, and if there is ectopic macula, that means that something is pulling the retina towards that side, and you should check that side to see the fibrovascular proliferations and traction. As you see here, this is stage 4B, which involves the macular area. And these are stage 4A, 4B, and stage 5 retinal detachment, which is total retinal detachment. Stage 5 ROP was actually previously described with the ultrasonographic definition. It was called as open posterior and anterior funnel, or posterior close, anterior open funnel, like that, with those designations. However, in the stage 5 ROP differs, the prognosis differs. Not all of them are the same. I have to say that if you have just total retinal detachment with some very different than this one, which is totally leukochoric, which is mostly associated with closed funnel type. And this is another stage 5, but very late one, which has corneal opacification. So, but these were all called as stage 5 previously. Now, with the last ROP 3 update, stage 5 is now subclassified as stage 5 ABC. A is if you have a weave-to nerve and the posterior pole, this is called stage 5A, total retinal detachment, but you have the weave-to posterior pole. If you have no weave-to posterior pole to optic disc, like these cases, it's stage 5B. They're usually associated with closed funnel configuration, but it doesn't have to be. And it's very easy to define this. And when you have corneal opacification or anterior chamber shallowing, then it's called as stage 5C, anterior segment changes. This is much more, easy and, honorable, I don't know, designation, because the ultrasonography does not always give very clear clues. So this is quite clear. When you see the posterior pole, it's 5A. You don't see it, just leukochoric, 5B, and then now 5C. Of course, you need to do ultrasonography again. And when we have plus disease, plus disease was first described by the first ROP committee as retinal vascular dilatation and increased tortuosity. It was defined in the posterior pole around the optic nerve head, and to call it as plus disease, it should be at least in 2 quadrants, at least 6 clocars, which is 2 quadrant. That was the classical picture, representative picture of plus disease in the first ROP paper. And this was a sign of active disease progression. Very, very important sign of active disease progression. And then in the second ROP paper, description of pre-plus disease was done. And they said that we may have some increased vascular dilatation and tortuosity, which is less than the representative picture of plus disease in the first ROP paper. And those should be accepted as pre-plus disease. And it should also alarm you as a progression. And in the last ROP, the committee members said that this is very subjective, and there are so many inter-observer variability. I can say this is plus. Another specialist may say it's plus. So, and there was no good agreement between the observers. And that's why the committee decided that this is a continuous spectrum of vascular abnormality. And you should assess it in zone 1. There's no requirement for the number of quadrants, but the main thing is that it's a spectrum from normal to plus. And the main thing is the tempo of the disease. If the dilatation is increasing in every visit, it means that it's a progressive disease. That's the main thing. And all the factors like demographics, clinics, zone, progression rate should be taken into account. The progression rate is the main thing that should be taken into account with the vascular dilatation. And they have published some representative pictures for normal, pre-plus, and plus disease within wider angle pictures, of course. And imaging is important, and this imaging can be done with, like very expensive machines like RETCAM, Forus, IconSoar. There are many machines for that. Some of them are supplied with fluorescent angiographies. And it can be also done with smartphone-based images. And it's quite, easy and quite cheap. It's important to do an imaging because it's important to see the tempo of the disease. You should compare the vascular dilatation in the previous one and the next visit so that it will help us a lot to see the tempo of the disease. And another description is aggressive posterior ROP. You know that this was described in the ROP papers again, and it was called as the most aggressive form of the ROP, which is in the posterior retina, zone 1 or posterior zone 2. There should be plus disease in 4 quadrants. So this is a peculiar type of ROP because the stage and extent of the disease is not important. You usually have just flat neovascularization. You don't see a, elevated whitish ridge. And when you see this with plus disease and, zone 1, then it needs an urgent treatment. And you usually have pupil problems. Pupil does not dilate well. So that should also stimulate you for the urgency of the disease. And it should be examined with 20 degrees. With the 30 degrees, you can miss the ridge area, which is flat neovascularization. And there's no visible whitish fibrosis. And it doesn't follow stages 1, 2, 3 order. It may become stage 5 very suddenly. So, for example, this is a typical aggressive posterior ROP described in the previous ROPs. You see plus disease everywhere, tortuosity and dilatation, and you don't see the whitish ridge, but you can see the end of the vascularization. This is the vascular area. Sometimes it may be very vague, and the choroidal vessels may be thought as the regular retinal vascularization, and they can say that inexperienced examiner may say that it's vascularized, so then it may become stage 5 suddenly. So be careful about that. Just check if there's plus disease, and if you see plus disease in the posterior pole very badly, you have to be very careful. For example, this is just posterior zone 2 stage 3 plus disease, which is, I will explain later. Type 1 ROP, type 1 pre-threshold ROP. You see the whitish fibrovascular rich tissue. So it's different than the other one. And in ROP 3, the name has been changed to aggressive ROP, not AP-ROP, but AROP, because they wanted to involve the oxygen-induced type of retinopathy into this. Because this is, the disease may not be, it doesn't have to be in the posterior pole only, as described earlier. It could be in the even the peripheral part, and it's usually related with the lower NICU conditions. neonatal intensive care unit conditions, and it's associated with plus and flat neovascularization as previously described. And also capillary non-perfusion may be present posterior to the ridge, which is in fluorescein angiography, you can see it very well, which is not a routine sign of ROP. You know, when you have vascularization, it's vascularized in posterior to ridge and avascular anterior to ridge normally. But if you have some ischemic areas posterior to ridge, that's something different. And it develops earlier than type 1 ROP. Maybe you should check it before the 4th week, postpartum, of course. And vessels are like that 3 branches. As you see here, only this part is vascularized. Even the zone 1 is not vascularized. And you can see some empty areas in between the vessels. These are very typical. You see some pathological vessels posterior to ridge area. And this is not a posterior disease at all. As you see, it's vascularized, but some pathological vessels have invaded. Again, some avascular areas in between the vascularized retina. These are all oxygen-induced retinopathy type of ROP. And since we didn't want to use that term because of the medical legal issues, so the committee decided that it should be, all of them should be designated as AROP, aggressive ROP, to involve the oxygen-induced type. So how should we follow and treat those cases? That's the one of the most important things, and the clinical studies just lead us how to follow and treat. These are the major studies that we have, and the cryo-ROP study was the first one, which described the threshold disease. Threshold disease was zone 1, 2, stage 3 plus disease. It should be at least 5 continuous clock hours and blah, blah, blah. But with the results of the cryo-ROP, we have seen that, of course, the cryo-treated eyes did better, but still they have quite a lot of, like 40% poor functional results, and it was almost 80% in zone 1, even in treated babies. That means that we should treat them earlier than the threshold disease. Then ROP comes. ETROP study described the pre-threshold type 1, which is high risk, and type 2, which is low risk criteria. In pre-threshold type 1 disease, we have zone, these are the treatment indications. When you have pre-threshold type 1, you have to treat those babies. These are zone 1 disease with plus any stage. So if you have zone 1 with plus, any stage should be treated. If you have zone 1 with stage 3, you don't have to have plus disease, you should treat. And if you have zone 2 with plus disease, stage 2, 3 should be treated. So these are the definitions for the treatment indications. And they also describe the pre-threshold type 2, sorry, and which is zone 1 with stage 1, 2 without plus disease. So when you have a zone 1 disease, you have to be very careful. Just check the stage, and if you have plus, go with the treatment. And for the zone 2, if you have stage 3, even without plus disease, you have to be very careful. You have to follow these cases frequently. That's very important. And all the others are low risk babies. You may follow them rare, like 2 weeks or something like that. I will talk about it. So follow-up visits as a general guideline. If you don't have any ROP, then every 2 weeks may be okay. This is just a rough guideline. If you have some ROP, this is just follow weekly. But if you have a pre-threshold ROP, then you should see in 2-3 days. And if you have incomplete retinal vascularization without any development of ridge, then just if it is in zone 1 weekly, in zone 2, 2 weekly, and in zone 3, even less frequent. If you have stage 1, 2, again, in zone 1 weekly, then rare in the other zones. And if you have stage 3, If it is zone 1, you have to go directly to treatment. If it is in zone 2, you should check the plus disease, for 3, depends. And for the anti-VEGF treatment studies, these are the major studies for anti-VEGF studies, and BTROP was the first one. BTROP was published in 2011, and they have used bevacizumab versus laser, and they have shown that bevacizumab eyes did much better for ROP as far as the ROP progression. And in addition to that, vascularization continued. We were just destroying the avascular retina with laser, but now with the anti-VEGF, vascularization continues. And the difference was much more pronounced in zone 1 disease. And that brought us a very important age for the treatment of ROP. And then the other studies come, the other molecules come. Rainbow was another one with ranibizumab in 2019. And they have also shown that laser group did worse than ranibizumab group. Ranibizumab dose was less than the adult dose. Of course, we routinely use 0.5 milligram, but here they use 0.1 or 0.2 milligrams, and even those did much better than the laser group. And additional treatments, which means recurrences, were higher in the anti-VEGF group, but when you add the laser to skip areas, so which is another, additional treatment, they were almost the same. And also another study was Firefly, and that was done with aflibercept in 2022, and in 2023, 2-year results were also published, and they used 0.4 milligram aflibercept versus laser, which is 1/5 of the normal adult dose, and that was a non-inferiority study, and the recurrence rates were again a little bit higher than the laser, 22%, but there was less myopia, and treatment success was quite high, like 81%, and it was approved after, and systemically also safe, and it was approved by FDA after that study. We have also some PEDIC studies done with bevacizumab in 2020. They tried even lower doses of bevacizumab. The first BTROP study was done with the half dose of the adult dose, but in PEDIC studies, they used, 1/4, even 1/8, and even to lower doses. And they have shown that, and they have done the higher dose in the fellow eye if the disease was better, bilateral, and the outcomes were almost similar. With the higher and lower dose, there was no difference in rates of reactivation in between the doses, and poor structural outcomes were very low. That means that probably very low doses of anti-VEGFs are quite enough. Maybe we can have a little bit more recurrences. In some of the papers it says like that, but they are very effective. And most of the studies have shown that they are systemically safe. So when we come to screening guidelines, how to screen, when to screen, which babies to screen. It depends on where you live, where the NICU conditions, what the NICU conditions in your hospital. For example, in USA, babies less than 30 weeks and less than 1,500 grams birth weight are routinely screened. In Ukraine, for example, 32 and 1,500 grams. And in Bulgaria, India, Romania, Georgia, bigger babies are screened. And also in Latin America, a little bit bigger babies are screened. And for Turkey, previous date was 32 weeks, less than 32 weeks, and less than 1,500 grams were routinely screened. But then we have the Turkish ROP study has been published, and we have shown that bigger babies have treatment-requiring ROPs like 34 weeks and 1,700 grams. Then we have changed our criteria to increase our screening guidelines. And this is the Turkish ROP guideline. We have done first published it in 2015, and we have again revised it in 2021 after the IROP 3 publication. So what we do, the first examination should be done either postpartum 4th week or postmenstrual age 31 week. Which one is later? But I have to emphasize that we were just talking with Susanna just before the start of my talk. Larger prematures need to be screened earlier because they develop treatment requiring ROP even earlier than 4 weeks. So I would suggest that 2-3 weeks may be better after birth, because we have just published a new study in big ROP babies, big ROP study by Turkish ROP group, and we have shown this because a big majority of such big babies have treatment requiring ROP even during the first screening period. Just to catch them earlier, we need to do the screening earlier, those big babies. So what do we need during examination? I just want to explain these things for the young colleagues who start the ROP screening newly. So we need a nurse to hold the baby in position to monitor during the examination. We need an assistant, if possible, to note the findings. And we need maximum pupil dilatation. We need an indirect ophthalmoscope with 20 and 30 dioptry lenses, if possible. And we need an eye speculum and scleral depressor. And for mydriasis, what I use is 2.5% phenylephrine and 0.5% tropicamide routinely. And we have, in some countries, they may be a combination of these two drops. And we put the drops 3 times, 5 minutes apart, and wait 40 minutes. And it's usually the best time to do the examination. And we should consider holding the feedings like 30 minutes or maybe an hour before the examination to prevent aspiration. Sucrose drops helps a lot. If you put some sucrose drops to the mouth and give a pacifier during the examination, it would be very nice. And if the baby doesn't accept pacifier, the mother can wash the hands and just give the small finger. They will feel even better. And instruments for examination may be like this. If you don't have a scleral depressor, you can use just a simple paper clip for indentation, which is very cheap. So we use this sometimes. And you can also have these nice ROP examination kits. They are disposable, but can be used a few times, and you can even disinfect it. And when you have a very sick, unstable infant, you can do some abbreviated examination. Please try to avoid any canceled eye examination. For example, the baby is very sick. They can say, the NICU may say that baby is very sick, so they cannot tolerate the examination. But you should do a very brief indirect examination just to check the posterior pole. Even with a very mild pupillary dilatation, you can check the plus disease, zone 1 disease, presence of, and the aggressive ROP. You can check it from the posterior pole. You don't have to indent the peripheral retina. You don't have to see everything, but just to check that it's not an urgency. If it's not an urgency, then you can postpone the examination 1 week later, for example. But don't skip it, please. If the baby is very sick, which means that ROP may progress even more quickly. So don't do that. Sometimes babies may have some, for example, adenoviral infection. Some people may not want to touch it, but you need to see at least the posterior pole very briefly. That's very important. Don't skip it. And you need to have a form for ROP examination and for the follow-up. These are Turkish because these are the ones we use in our institution, but you can have the general condition, ophthalmological findings, and the follow-up part in these forms. And also, if you treat the baby, you need to have a treatment part for the follow-up. And they should be, the general part should be filled by the pediatrician or nurse of the NICU, and then you can fill up the other parts. When you do the examination, you need to decide on two things, two decisions. The first thing is, should you treat or not treat? I mean, the eye needs treatment or not. So this is the first thing. If you think that it should be treated, you should do it within the 2-3 days. If it's aggressive ROP, you should do it on the same day if possible. And the second thing you need to determine is, when is the next examination? It's very important because, if it is very high risk, you should see like zone 1 without plus disease, you should see the baby in 3 days, 4 days. If it is a high risk pre-plus zone 2 or stage 3 without plus, then see in 1 week. And if it's a low risk, like zone 2, zone 3, see in 1-2 weeks at most. So no need to be more frequent. And follow-up visits routinely. If you have only incomplete retinal vascularization, do it every 2 weeks. 2 weeks, 1 week, or 2-3 days. So you should decide on these things. If it is very high risk, like pre-threshold therapy, just 2-3 days. This is the important one. So when to stop follow-up? Sometimes it's like never-ending visits. If the vascularization reaches zone 3 without any ROP development, just leave it. You don't have to wait for the vascularization of the zone 3. But if there's some ROP developed, you should see the vascularization of the zone 3. It should be completed. But after the use of anti-VEGF, in the anti-VEGF era, we have quite a lot of persistent peripheral avascular retina. So it's not completed how to behave to those problems. And everybody can see me, can hear me. I hope everything is fine.
Yes.
I feel okay, perfect. So when we come to treatment, we have 3 types of treatment. You can do laser. I think no one is doing cryo at the moment, or anti-VEGF, or vitreoretinal surgery if we have retinal detachment or vitreous hemorrhage. What we do which treatment to which babies? We do laser if the disease is not too posterior. In anterior zone 2-3, I always do laser, almost. And if I don't have any pupil problem, etc. If it's a posterior disease, aggressive disease, zone 1, posterior zone 2, if you have pupillary problem, if the general anesthesia, if the baby is very sick, if I can't put under general anesthesia, because I do under general anesthesia, if the disease is not, too limited, then I need general anesthesia. So if I can't put under general anesthesia, then in those conditions, I prefer anti-VEGF treatment. And if there's retinal detachment, vitreous hemorrhage, then I prefer vitreoretinal surgery. For laser treatment, what are my tips? So you need very good pupil dilatation. That's the first thing. And when you do the laser, it should be like a staining pattern. So the spots should be almost complete, maybe like half spot apart. And even in the posterior part, even more confluent. It should be. In the peripheral part, maybe a little bit more distant, but in the posterior, more confluent. And in the 3 and 9 o'clock position, try to have lighter laser burns than the other parts to avoid the anterior segment ischemia and also the pupil problems during the laser. And indentation and relaxation should be very gentle during the treatment. When you indent very densely and then you relieve, then you can have pupil problems. And I don't do laser posterior to reach mostly, but if there was flat neovascularization, if you feel so, maybe you can do that. But those are usually associated with aggressive ROP, and in those cases, I usually don't do laser, but anti-VEGF. And after the laser, since laser causes some inflammation, I use steroids and tropicamide and some antibiotic just to prevent secondary infection after the treatment, like a week. And you should avoid skip areas, and you should check it again and again. If you have a fundus picture available, you should check at the end of the laser if there is any skip areas, and you shouldn't let any skip areas. For example, these are the typical laser treatment for an aggressive ROP. This was from old days. So regression after laser starts later than anti-VEGF. So during the first week, the only thing you need to see is it doesn't progress. After the second week, you will see that neovascularization will start to regress, and the hyperemia will regress, plus will start to regress in the second week, even at the end of the second week. And there is no elevated reach after the second week. You see, this is the beginning, and this is after the first week. You see the reach is still very vascularly active, and by the end of second week, you see the vascular activity is very little. So a follow-up visit should be like this after the laser. You should see the next day just to check if there's anterior segment ischemia or anything, any bleeding, hyphema can happen. And the first week, and then second week, then if everything is going well, you can increase the intervals after the regression of plus and neovascularization. And then this is one of such examples. You see we have lasered, and you see within time it goes away, and the neovascularization is totally regressed. If you see any skip areas, it should be treated as soon as possible, especially in the posterior area. It should be done very quickly. You shouldn't leave these avascular areas. They proliferate very fastly, quickly, and don't leave them alone. And when you see attraction in the ridge area, even after your laser, please don't do barraging laser posterior to the elevated ridge area. This doesn't prevent progression of the tractional retinal detachment, and you will just laser the macular area when you do that. Just refer these cases for surgery. When you see an elevated retina, which means stage 4, then please refer them to surgery. Don't do additional laser, like in this case, where the macula is totally lasered, unfortunately. So what are the advantages of laser? You have peripheral retinal stabilization, which is very useful if surgery is needed, and for future life, because you will not have lattice degeneration in those areas. And avascular retina is totally ablated. Once it's regressed, you don't need frequent retinal examinations as opposed to anti-VEGF treatments, and you have very low recurrences. And however, you need, in the posterior disease especially, you need general anesthesia. There are some colleagues who does in local anesthesia or topical anesthesia, but I do it in general. And it's a longer, tiring procedure for the doctor, needs more experience, steep learning curve. Peripheral visual field is totally ablated, especially in posterior disease. It's a very bad disadvantage, and it induces more myopia and astigmatism. Sometimes we may have anterior segment ischemia, which is almost a disaster most of the time, unfortunately, and it may cause exudative retinal detachment and it causes more inflammation and posterior synechial complications. And additionally, you can have some disc herniation problems. This was my MRI in 2009, where I have a bad, pain and that disc herniation. But thanks God, I'm fine right now. After some precautions, it was much better. And when we come to, for example, sorry, I will just close this. When we come to anti-VEGF injections, it's easier. As you see, it's better to use safer ROP technique, which is published in 2020 with short needle. I don't have 4 millimeter needles, but it's good to do with the shorter ones. And you need to do a betadine sterilization of the field, and you need to follow up in 2-3 days after injection, just to see if there's any endophthalmitis or anything like that. And extra attention should be done to details, like you should do the injection 1 millimeter posterior to limbus, and I stabilize the eye with a cotton bud from one side and then inject from the other side. And usually my assistant presses the plunger when my hand is stabilizing the needle. And you should recheck it 1 to 2 weeks following injections until mature vascularization comes back. So regression after anti-VEGF is much earlier than laser. Even just the next day, you may have the regression of the plus disease most of the time, if not the next day, in the following few days. And plus disease regress, vascular activity regress. And if you don't see any regression, that means that most probably, especially if asymmetric responses from both eyes, that means that your drug did not go into the vitreous cavity, maybe just reflux or something like that. So you should be suspicious about that one. And after the second week, usually progression of the vascularization towards the periphery starts, but it sometimes never reaches to ora serrata, and it may cause persistent avascular retina. And the follow-up visit should be the first 3 days. You should check because it may cause endophthalmitis. And then first, second, and fourth week, and monthly after, if the disease is already under control, monthly until you see the total regression of plus and neovascularization and total peripheral vascularization. Sometimes a recurrence may appear and second injection may be needed, rarely, especially in very posterior disease. This is very typical, you can have this remaining tortuosity. It's not a plus disease. This tortuosity, without dilatation of the arteries, may remain in most of the ROP survivors. It's not a sign of active disease, but we can see this persistent avascular retina after anti-VEGF. And this is, for example, one of my patients, 4 years after anti-VEGF treatment, vision is quite good, but we have persistent avascular retina associated with some neovascularization in the rich area. We can have some peripheral vascular abnormalities. We can see them very well with the same angiography. And we have published this data. Avascular retina PAR is present in 75% of the cases. And in ROP-treated eyes, it's like never-ending visits. We can have late recurrences, we can have avascular retina, and in that avascular retina, we can have lattice degenerations, vitreoretinal interface pathologies, membranes, which may cause retinal break and retinal detachment in future life. And what I do is, when the baby becomes bigger and bigger, it is difficult to see the peripheral retina, and we can't put it under gel anesthesia every time. So when I see that baby is quite good, and if I can't see the peripheral retina well, like at 60 weeks of postmenstrual age, then I usually do laser in those cases just to be sure that peripheral retina is under control. For example, this is 67th week postmenstrual age. You see still avascular retina in zone 2, and would you just leave it alone? I would do laser like this case, but it shouldn't be too dense. It's not like in acute disease. It's like you do in proliferative diabetic retinopathy. So just get your laser. And what are the advantages? It's an easy procedure under topical anesthesia, and peripheral retinal vascularization continues, which means that peripheral visual field defects would be less, and myopia is less. These are very good. This is from the BTROP study, and we have some disadvantages, of course. We may have endophthalmitis risk, lens and retina damage may be another risk, and we can have some potential systemic central nervous system side effects, although unproven, although most of even the meta-analysis of the anti-VEGF studies have shown that there is no such systemic risk. We have a potential risk, and we have avascular retina, which may cause late reactivation, lattice degenerations, and rhegmatogenous retinal detachments. Another potential problem is the crunch phenomenon after anti-VEGF study. This was described in ROP3, and crunch phenomenon was described in proliferative diabetic retinopathy, as you know. So the fibrotic component, if the fibrotic component is high, and if you inject the anti-VEGF in the late period where the VEGF level is already low, then it may cause contraction of the fibrotic tissue, and tractional retinal detachment on retinodiscisis may come. And as you see here, this eye was injected, and then you have this tractional retinal detachment. This is crunch syndrome. You see, this is before and after the injection. So you shouldn't inject in late fibrotic ROP cases, but it should be during the high VEGF levels. You remember my schema of the pathogenesis? So you should inject anti-VEGF during the high VEGF level period. Okay, then we can have reactivations. Reactivations may be seen, mostly after anti-VEGF injections, very rare after laser. Only if very aggressive disease maybe, or if you have skip areas, you can have reactivations. But in anti-VEGFs, like 20-30% of cases may reactivate, maybe even after full regression or partial regression. When you have a reactivation, you can have reactivation in the primary reach and the secondary reach area, and those should be designated as suggested by ROP3 study. And it's not like the acute disease. You should never wait for fulfilling the type 1 threshold ROP criteria. Although there's no consensus for the treatment criteria, when we see a reactivation, we always do treatment. I personally treat the reactivations with laser if it's not too posterior disease. But if it is still in the zone 1 or posterior zone 2, even the reactivation, then I do inject, but otherwise I always laser the reactivated cases. And what are the signs of progression to stage 4? We can have vitreous haze and opacity over the ridge area or optic disc area, and then that should alert you. If you have vitreous hemorrhage all in a sudden, that should alert you. If you have a thickening of ridge, or if the plus disease is becoming, more and more after treatment, then you should think of progression to stage 4. It's usually after 45 weeks of postmenstrual age. And it should be then referred for surgery not like this. This was referred to me after the second laser. Although I did surgery, it regressed very well, but the macula was already lasered. So don't do laser, but refer when you see those signs. And for the surgical timing, when you see that the angles between the arcuate vessels become narrower, or if you have macular ectopia, that means that there's something in the peripheral part. Even if you didn't see at the beginning the peripheral tractional membrane, that should alert you to check the periphery, and you will see. For example, in this case, when you first look at you don't see any tractional membranes, but you see that macula is very ectopic. The angle between the temporal arcuate vessels is very narrow. And when you check the periphery, you will see that elevated retina caused by tractional membranes. And you can also have some volcano-shaped tractional retinal detachment, stage 4A. These are usually after aggressive ROP treatment. You can see volcano type. Peripheral retina is attached up in the center, you see the traction. And when we come to surgery, when you see those signs, we should treat the eye with the surgery. But the surgery for stage 4-5 is, a pediatric vitreoretinal surgery, and they're very different. They behave very different. The eye is very small. We have very small area for maneuvers. Lens is relatively large. Pars plana is not developed. Sclera is thin and elastic. And we always try to do lens sparing vitrectomy if possible. And at the very beginning, what I do is just try to do contotomy so that the narrow space is widened. Now I have more space for the maneuvers. And we need shorter trocars. And this is a very easy way of doing a trocar. You put a silicone tip, anything, before the trocar as a spacer so that you have a shorter trocars. For the small eye. And for the sclerotomy, we usually enter the eye from 1.5 millimeter posterior to limbus, and you can arrange accordingly when the baby is growing up. It reaches to the normal adult level at 3 years of age. And you can do limbal or transiris route entry if you are planning a lensectomy vitrectomy. Otherwise, enter the eye 1.5 millimeter posterior to the limbus. And sclerotomy site is one of the most important stage. Retina is pulled towards somewhere. It may be in the temporal part, nasal part, anywhere. You should check first if the retina is in the periphery, and you should avoid those parts to enter. Otherwise, when you enter the eye, you will end up with a retinal break. It will be injured with the trocars. And we should always do conjunctival peritomy, and I always suture all the sclerotomies. But the most important part is to avoid from to avoid the peripheral retina. For example, retina is totally direct towards the temporal periphery in this case, and then infusion was taken to the nasal side. Sometimes all nasal entrance may be done, sclerotomies may be done, because the base of the nose is not developed well, so we can do it even from the nasal side in babies. So the main principles for the vitrectomy is to relieve the traction as much as possible, remove the membranes as much as possible, and you don't have to peel everything. Just leave the ones that are very risky. That's it. And we try to remove the posterior hyaloid in the posterior pole only, just outside towards the outside of the vascular arcades, not towards the rich area, only from the posterior pole. And if that's possible, if that's not possible, if you feel that it's very risky, just leave it there. You don't have to do that. But when you can do the posterior hyaloid removal, you will avoid from late posterior hyaloidal contractions, which may cause tractional retinal detachment in future. And we always try to preserve the lens. That's also important. So this was one of my life surgery cases. And you see, I always put a pre-placed suture to avoid hypotonia at the end of the surgery. And always use, you see, there is a silicone here to make the trocar shorter. And of course, before entering, you have to check the periphery, like in this case. And then after entry, we have some proliferations from the ridge area to the disc, from ridge to the periphery, from ridge to the lens, to the back of the lens. So what you need to do is just to cut those connections. That's the only thing. So you just cut the connections, and you don't have to peel in stage 4A. You don't have to peel any membrane. You can just leave it there. But if you feel that it's not vascularly very active, and if you feel that it's causing kind of contraction 360, then you can have, if it is peelable, you can peel. You may not see even one red blood cell during the surgery because the perfusion pressure is very low in these eyes. We always use very low infusion pressure, like 15, at most 20, and you may not see any bleeding during the surgery. But at the end, from those rich areas, if you do too much manipulations in the rich area, that may cause bleeding, postoperative bleeding. And as in this case, we use a lot of triamcinolone again and again to trim the posterior hyaloid. And we always do, of course, laser to the peripheral avascular retina and try to detach the posterior hyaloid if possible. In this case, it was possible to peel the membrane, which was easy to do that in this case, but you don't have to do it. If it was stage 4B, you have to peel the membranes to relieve the macula. But since the macula is already attached in stage 4A, you don't have to. This is the post-op appearance of the case after the surgery. This is another case. As 8 years after bilateral vitrectomy, the vision looks good, but we have high myopia and astigmatism for sure. And this is a stage 4B case. You see, this is before the surgery. This is 2 years after the surgery. You don't have to peel everything. You see, we leave some parts of the fibrotic tissue, but it stays there. You don't have a retinal reattachment at the beginning, during the surgery. You just leave the traction, leave it there. I leave the eye in air in almost all of them. But if I don't have any retinal break like that. This was another case. Right eye, stage 5 and 5B, and left eye, stage 4B. And we did the surgery to the stage 4B eye. As you see here, again, a spacer is used and a pre-placed suture is there, 1.5 millimeter entry point from the sclera. And again, for this case, since it's stage 4B, we have to peel the membranes, not just cutting the connections, but we have to peel the membranes. But of course, you can't peel everything, but you try to peel as far as you feel safe, okay? If you feel that that part will be risky, may cause vascular arcades to bleed, or it may cause a retinal break formation, then leave it there and go another way and peel more membrane from other side. Try to peel as much as you can. And then retina is will be detached at the end of the surgery. You will leave it like that. So you don't have retinal reattachment on the table, but you just relieve the tractions. It goes back itself, okay? You do laser, just leave the eye in air, and then this is the post-op appearance, and this is 5 years after the surgery, and vision is 0.3, quite good. So ROP surgery is a kind of surgery where the surgeon should know where to stop. This is very important. And perfect is the enemy of good. I always say this. And do not let any iatrogenic retinal break formation, which may be the end of the surgery. For example, this was a case, and I had to peel the membranes, and then I had stage 4B, of course. I had a small retinal break in that area, and then I I just tried to peel the vitreous only around that area because I was not being able to peel the posterior highlight everywhere, and then did laser and put gas only. And this is after resorption of the gas, retina was quite attached. Or you can also think of putting a cryo, doing a cryo and putting a local buckle to the area of retinal break, because it may not be possible to relieve all the tractions in the most proliferated areas. So a local buckle may be a good option. You can just use a small piece of, any buckle you use for the adult cases. You just put a small one and it may also work very well. And we have published our data on stage 4A cases in British Journal in 2018. And we have shown that in stage 4A, anatomical success reaches to like 90%. In stage 4B, it's like 70%. Functional results were dissimilar. And we have also shown that when the positive predictive parameters were when you have pre-op treatment with anti-VEGF or laser, when you have lens-sparing vitrectomy, and when you could do a surgically induced PVT, they are good prognostic signs. But when you have pre-op plus disease, when you have post-op vitreous hemorrhage or iteration retinal break or need for lensectomy, those are negative predictive outcomes. So when we come to stage 5 ROP, should we operate? Everybody's asking that. Actually, yes, we have to operate. Why? I will explain. So this is a stage 5 ROP. Natural course is blindness with unpleasant cosmetic appearance with corneal opacification in most of the cases. In stage 5A, for sure, we need to operate. For stage 5B, mostly yes, and especially for cosmetic purposes. For stage 5C, if it's not too advanced, maybe we can do the operation. But we have to explain the family that visual expectations are very low. Preservation of just light perception, or if we're lucky, just an ambulatory vision would be the best thing, not more than that. And even if we can't have those things, we have anatomical and cosmetic purposes. So they should understand this, I mean the families. So this was a stage 5A case. You see total retinal detachment, and the pupil dilatation was mid dilation. And you see, we just cut the fibrotic tissues as much as we can. And we tried, since the peripheral retina was lasered, so we could find a place to enter the eye from the periphery. Otherwise, we have to do lensectomy vitrectomy. But for this case, we could clear it, and then we could go further. Although periphery was not good, you will see these tractions. We tried to cut the connections as much as we can, and then this baby could have quite good ambulatory vision. Another case, we did with stage 5A in 2011, very early years. We did the first surgery, and then we can do stage surgeries. If when you leave the eye, you just leave as much as you can. Then retina goes backwards and the retina starts to attach in most of the parts. And then you still have some membranes, then those become even better visible. And then 6 months, 3 months, something like that later, you can do the second surgery to relieve more membranes, as in this case. So this was a stage 5 case. After 6 months or 3 months, we did the surgery. You see, since retina is now attached in most of the part, it puts more resistance for your traction so that you can peel more membranes. And after this more peeling, this was the end of at the end of the surgery, we could peel more membranes. And this was 5 years after the surgery. You see, this is my best stage 5 case, which point to vision. He's going to normal school and he's very happy. And although we have some, folds, the macular area looks not bad, quite good. And this is another case. This is stage 5B. For stage 5B cases, We usually do lensectomy with rectomy, and most of them has closed funnel, but it doesn't have to be a closed funnel. You try to peel the membrane, starting from the center towards the periphery, layer by layer. When you relieve the tractions, retina starts to go backwards even during the surgery. And then you try to peel more and more. And then when you feel that it's not safe to do more, just leave the eye in air. I use only air as a tamponade. And when it goes backwards, you can again do the second surgery. So stage surgery is quite common. In such advanced cases. This is another stage 5B case. Again, we do, it's actually not a difficult surgery, but you need to know where to stop. You start from the center, layer by layer. When you see the retina, you have to be cautious. And of course, the peripheral retina could not be relieved totally, but it will become better than before. And even if the retina is not totally attached, if you have some small attached parts, that will help the baby to have some orientation. Even if it is totally detached, like in this case, but the surfaces are still concave, which means that retina is backwards, those eyes have some light perception, some head motions, vision, which is very good, very, very helpful for the baby. It helps to, stimulation of growth hormone for the day and night. These are very important for the babies, even for the growth. And we have published our data also for the stage 5 eyes in retina in 2020. And we have shown that in stage 5A cases, we have like almost anatomical, some attached retina in 60% of the cases, but in stage 5B only like 15 to 20% of the cases. Functional results were the same. Again, negative and positive predictive things were similar to stage 4 cases. I just want to show some examples. This was stage 5B case. One eye, and stage 4B in the other eye, coming from abroad. This was the stage 4B eye macular fold with the peripheral, and the stage 5A, 5B eyes has closed funnel retinal detachment. The other eye was only having, say, partial retinal detachment. And this is the post-op appearance of the stage 5B eyes. We could open up the funnel, and then in the front part, it was looking like that. And this is the ultrasonography, which was previously like that. And you can see that although some, of course, still elevated folds, but we can have some attached retina parts. And those attached areas give the baby quite nice orientation, sometimes ambulatory vision. This is the fellow eye with previous stage 4B, which was like this. Now it's quite good. Macula is attached and he is freely mobile. And this is another, one eye is stage 5B, one eye is stage 5C, because there is some iridocorneal even adhesion, not the corneal opacification yet, but it started. So it was closed funnel. And then with the surgery, we could again open up the retina, right eye, left eye. You see those exudations during the resorption of the subretinal fluid, and retina is totally attached in these cases. So if you don't do the operation, this was such a case. This eye was operated for stage 5, but the fellow eye was not operated. And you see the operated eye looks quite nice, and the other eye looks quite bad. So cosmetically, I mean. So this is not only a functional, but also a cosmetic surgery. If you don't operate these eyes, you see eye becomes phthisic and the cornea becomes opacified. This is the routine way. And families should be informed about these realistic expectations. And sometimes we can even do the surgery only for the cosmetic expectations. And, at these years, we are having, too much cosmetic things. We ladies having Botox, many things just for the cosmetic appearance. And the eye is the most important part of the face. So it should be very important to have just the cosmetic results. So coming to the cicatricial ROP, I think we have just 5 minutes to go. And for the cicatricial ROP, which means during the adolescent part, we may have high myopia, astigmatism, glaucoma, vitreous hemorrhage, late reactivation, retinal detachment. All those things can happen. So that's why these babies have to be watched lifelong. For the retinal detachment, we can have rhegmatogenous or tractional retinal detachment. And when we have rhegmatogenous retinal detachment, since they have high myopia, they are usually misdiagnosed as Stickler disease. So you should ask about prematurity if you have an adolescent rhegmatogenous retinal detachment with high myopia, okay? And be sure that these are more complex detachments, more likely to require multiple procedures. We have much lower expectations, and like 2/3 of the patients who underwent vitrectomy had poor postoperative visual acuity. And we can have regressed cicatricial ROP after anti-VEGF laser, or even after spontaneous regression. We can have avascular retinal lattice degeneration, vitreoretinal peripheral degenerations. For the prophylaxis of retinal detachment, we can do encircling scleral buckle if the peripheral vitreoretinal tractions are quite evident. But if you don't have any significant tractions, you can do just 360 wide-based laser photocoagulation as a prophylaxis. This was old male who was followed in USA and who was premature but did not have any treatment, just spontaneous regression, had bilateral laser photocoagulation in both eyes. But look at that. Macula is ectopic. The angles are narrowed between the vessels. Although the macula looks quite good, the peripheral retina is totally avascular. Just some local lattice degenerations were lasered, and we have some avascular retina and neovascularization. So what I did in this eye is just did total laser to those avascular retina. This is another 14-year-old boy. And you see the vision is quite good. Born prematurely, no treatment before. The peripheral retina was so awful. There were so many vitreous membranes causing too many vitreous tractions. So I couldn't, do any laser directly, but I did first scleral buckle to relieve the traction, because sometimes when you do laser, it may even contract the present membranes and may cause traction. And you may induce retinal detachment. Just to avoid that, I do prophylactic cerclage first and then laser photocoagulation afterwards. And another case, this was a premature baby, prematurely born, 11 years old man who was, followed somewhere, but this was the bad eye, already bad eye with macular fold. This was the good eye. It was previously seeing 0.3, but now just counting fingers with total retinal detachment. These are not PVR membranes, but previous cicatricial changes membranes from the ROP. And I did just laser to the peripheral avascular retina in the right eye, but we have to do vitrectomy for the left eye because I couldn't see any retinal break. Probably it was under membrane. So if I can see the peripheral retinal break, I would definitely do just scleral buckle, no vitrectomy. But since I couldn't, I have to go on with the vitrectomy, and I have to peel as much as I can. But you don't have to. I wanted to avoid from peeling everything. I don't want to induce new retinal break because when you have additional retinal break, it will make the prognosis even worse. Then I could find a retinal break in the superior periphery, and I just peeled the membrane, posterior hyaloid around it. But since it was already vitrectomized, although I peeled the ILM, everything in the macular area, but there were some, I did laser, there were some very adherent membranes which will cause formation of retinal breaks, so I just left some of them. But it didn't put silicone oil for this case. But as you see here, first day okay, first week okay, no macular problem. And then it developed a macular hole, newly formed because of the contraction of some left membranes. It caused macular hole formation. I have to put an amniotic membrane to that macular hole. But again, the other parts contract, and I had to do 5 surgeries. And after cataract and silicone oil removal, retina was attached, but just counting fingers. So and it may end up with total retinal detachment and loss of the eye also. But it's very demanding and the results are very poor. So we should try to avoid rhegmatogenous retinal detachment during adolescence period. So do whatever needed as prophylaxis. And this is another adolescent, 13 years old, came with chronic inferior retinal detachment, but this could be also, tractional component, because I didn't see any retinal break. The surfaces were kind of concave again, so I put only 360 wide encircling buckle, and it worked very well. And we have also published our data in rhegmatogenous retinal detachment associated with ROP, and we have shown that encircling buckle is the best to treat those rhegmatogenous retinal detachment. And if you go with vitrectomy, you need to combine it with the scleral buckle. Otherwise, only vitrectomy is almost always failure. So do scleral buckle, either scleral buckle or combined vitrectomy with scleral buckle. So when you have a tractional retinal detachment, should we operate it? Like in this case, for example, this was again, the vision was vision was 0.1 and 6 years old. Macula was attached, but there were so bad tractions in the superior periphery. Macula was very ectopic. So since I see that it's anteroposterior traction, if it was tangential traction, I wouldn't touch. But since it was anteroposterior traction, which feels like removable traction, then I go with the vitrectomy, and it ended up with very nice result. And this is another case. You see there, the retina was dragged inferonasally in both eyes, 6.5 years old, prematurely born, no treatment before, vision is 0.1. And should we operate? If we operate and if we have a retinal break, something like that, we can lose the present vision. So it's very important decision. For this case, I decided to do surgery because you see again anteroposterior traction. It was reaching to the back of the lens, and I was sure that the macular detachment was a recent one. So that's why we just cut the connection and then peel as much as we can. You don't have to peel everything, but peel as much as you can without causing any retinal break, and leave the one if you have some membrane which is very adherent, then leave it there. And what happened is that you see macula was attached and vision improved to 0.7, which changed the life of this child. And macula was attached very nicely. We did the same thing to the left eye. Vision reached to 0.3 only, but was good. This is another 4-year-old. The fellow eye is totally corneal opacification, but this eye was having some hand motions. There was no corneal opacification in this eye, and family was very willing to have the surgery. And you see the back of the eye was not so bad, not like closed funnel. Although this was 4 years old, I did the surgery and it went very well. And this was the post-op appearance. After 3 years, you know, they could see 20/400, which was very amazing for me. So vitreoretinal surgery may lead to very good anatomical and functional results in some selected scut residual ROP cases, not all of them. Of course, we have published our data. If you like to see them, you can just check the papers. So it's a lifelong disease. Oh, Am I too late? Almost
No,
the last
sorry.
slides.
It was from somebody else. I will mute it.
Okay, so it's a lifelong disease. You should be careful for persistent avascular retina and late fractional retinal detachment, reticulogenous retinal detachments, and glaucoma, amblyopia, strabismus, anisometropia may all happen to these eyes. And you should be also careful when you see an atypical course, like very late reactivations with some exudations. If you're not expecting, you should check the differential diagnosis, like fever, colds, incontinentia pigmentum, nori, extinct retinoschisis, PFE, everything may, simulate the ROP. And you should also check the systemic condition, especially the anemia, pancytopenia, which may worsen the condition. And also this keratosis congenita, which is a telomere biology disorder, and CAPN5 mutation, they all make the prognosis much worse and different. So check the differentials. And for the differentials, be careful that when you see a premature with a retinopathy, not all of them are premature retinopathy. They may have all those things which may simulate ROP. So you should not only look at the retina of the baby, but also look at the face, skin, family history, hearing difficulty, blood pressure, and genetics. And last few words for telemedicine. These babies need specialists who can do the screening. And telemedicine may be helpful in areas where there is lack of trained examiner, but it needs high quality images. We can have some medical legal problems. And artificial intelligence may solve some problems like inter-observer variability, but this can be solved with it, but we have still quite a lot of problems with AI. You want me to do anything? Sorry.
No. Please,
may I continue?
please continue. Actually, they are unmuted, which was.
Okay. Sorry. Sorry, something happened. Okay, now. So telemedicine has some ethical, technical, clinical, regulatory, and financial considerations. And we can have medical legal problems with ROP, but if you have talked to families sufficiently to give information about the disease and prognosis, you usually don't have these problems. Good communication is the key. Records must be very good, and it should be very good communication between ophthalmologists, neonatologists, anesthesiologists, family, even with the NICU nurses. So I would like to thank you all, and I would like to invite my friends who are interested in this, in ROP, to come to our third international ROP course, which is a hands-on training course with simulators and with even the neonatal resuscitation courses there, also indirect laser to modulize is there. So please come and join us in next October, and also for the EVRS meeting in Cancun this year in November. And if you're interested, you can have more information in our pediatric vitreoretinal surgery. Thank you. And I think I was a little bit late to conclude. Thank you.
Thank you, ma'am. Thank you for such an informative class. I think we are all enlightened to practice more and more ROP. And we shall definitely be in touch to have any further queries. I think before we take a few questions, we can have a few expert comments from Dr. Susanna and Dr. Mariana, please, ma'am.
Happy to answer. Yes, please.
Hello. Here is the morning city. This is my office. And well, I think that in the last years, the ROP has advanced hugely in many ways. But I think that the take-home messages, and I guess that my co-chairs will be agree with that, is one, the individualized treatment. Not every baby needs only anti-angiogenic. Not every baby needs only laser. Combined therapy is for many babies, not for all of them. Surgery is accessible. And one thing that we have seen here in Mexico, and I don't know if in the rest of the world, is this rivalry between pediatric retina and some of pediatric ophthalmologists, that they delay the surgery and they try to save the eyes when they are already within an initial retinal detachment, when we can do so much to save this eyes. Also, remember what you just said, this is a lifetime disease, because many patients that they say, okay, they did injection and they let them go and they never see them again. If they have injection, if they have laser, if they have buccal, if they have whatever treatment they have, they require periodical screenings in any modality of treatment, or even the ones that were not treated. Why? Because we can have sequels during all our lifetime. So that's why we need to follow up them along. And I think that these are and also, for example, laser, if we do anti-angiogenic first, we don't have to laser all the way to the zone 1. We can laser only periphery because the vessels are going to grow. I think this is one of the major changes that anti-angiogenics have given us. The laser still has a role, but it's a role that is just to preserve better vision with less complications.
Okay. Thank you, Şengül, for this wonderful presentation, and you touch almost all the items about ROP. Well, I agree with Mariana about the take-home messages, that it's a sniper disease. The time matters in this disease. Really, it's one of the diseases where the time really matters. And it's a lifetime disease. I mean, we have the babies that we treated 30 years ago, 20 years ago, are still our patients. And so it's a huge burden to have to treat this and to accompany this kind of disease. ROP is a developing disease. What do I say? Has technology develops, then you have new presentations that still don't understand completely about it. So nowadays, we have the dichotomy. The nano and micro babies that are a problem have some kind of presentations of ROP that we still are decoding, which is the best way to treat and the best time to treat. Of course, as soon as we have type 1 disease, we treat. But then the follow-up is a little bit different about these nano and primary babies. Then we have the micro babies that we spoke about before this meeting. And we still are, I think, preparing and adapting to these variations from babies, nano and micro, and babies still have in the same NICU this kind of babies as we do have now in Portugal. So technologically, we are very well in Portugal. So we have nano and micro babies, but now we also have, as you have an incoming population from all other parts of the world, we begin to also have micro babies, that it's not only because of the NICU conditions, because NICUs are quite well now, but because I think they are from another country and with different genetics and different behavior of ROP. So I think the message is really there. And that's very wonderful, because Şengül came from the physiopathology to the genetic and the sequel disease. That is very important to control this sequel disease. You must never abandon those dead people. So I think it's wonderful, Şengül. And if there are any kind of course, we had a lot to debate. We could debate more. We could debate even surgery. You could debate anti-VEGF as a single therapy, as I do from many years ago, or some kind of combined therapy in some kind of presentations. If do laser first, anti-VEGF after, or if you do anti-VEGF, why do you have to do laser? Why don't you wait for the disease to see how it behaves just with anti-VEGF? And if you has a recurrence, yes, you can do or another anti-VEGF, or you can do laser. And reactivation is an interesting debate issue, because I've got some reactivations and they are new to me. That's why I speak about nano on primary and micro babies. I've got some reactivation in babies that have type 2 disease, not type 1. So they never had disease to be treated, but as they were born so little, 23, 24 weeks of gestational age, they don't have recurrent disease, but at 8 months of postnatal age, they have somehow reactivation of the disease. And that's why I say we are trying to adapt to these new babies, very, very little babies. And I can see this kind of reactivation that I think we must still think a lot about it. What are the risks for this late reactivation? 8 months, 9 months postmenstrual age in babies that had never ROP that needed to have treatment, type 2 ROP. And I think we have still a lot of things in the 21st century, a lot of things to know about this disease. So what's fascinating.
Yeah, Susanna, you and Mariana, you have emphasized very important points. Actually, we don't know some of the responses of some of those problems, and we have quite a lot of questions from the audience, and they're about the recurrences and reinjections also for the late reactivations. I have to say that we don't have any evidence-based medicine about this, how to behave to these reactivations. What I do, I'm just mentioning what I'm doing is that when someone was asking, when you have avascular retina in zone 3, stage 3, something like that. So do you do laser? How much should we follow those cases? What I do is I do laser. When the baby is, I follow the baby as far as I can. Then the baby is becoming bigger and bigger, more strong, and it's difficult to follow the peripheral retina. Then since it's stage, it's just a small area. It's not a big problem to do the laser. Then I do laser, and the families become relaxed. We become relaxed. So I prefer. And since I'm pediatric retina person, I see quite a lot of ROP survivors who come with rhegmatogenous retinal detachment in adolescence period. So that since I see them and since the prognosis is really bad, so I prefer to stabilize the peripheral retina because there are so many vitreoretinal pathologies in the periphery. So when you do the laser, at least you have some stabilization. And sometimes with the growth of the eye, those fibrotic components since they are rigid, if they are rigid, when the eye grows, it pulls more, and it may still induce some retinal detachment, some tractional, sometimes rhegmatogenous. So in such cases, I put encircling band when they are adolescents. So not when they are small babies, but when they are adolescents. So it's an unknown issue for sure, but we are trying to get some information about that. And Susan is asking about what do you do when you have a regressing pre-plus or plus? Should we wait, or how frequently should we observe a plus disease? Would you like to answer, Mariana, for that question? When you have a plus disease?
Well, first of all, you have to see if it is really ROP, because many cases that these very tortuous vessels, sometimes they are just because the lungs and the heart are not working well, and they have this congestive retinopathy that is just because of the lungs. It's not ROP. So you have to do a good differentiation between what it is ROP and what it is not ROP. Sometimes angiography, it helps us. We perform a lot of angiographies. And also in reactivations, you have to go back and see if it's ROP. It could be a ROPER, it could be a fever, it could be a cytomegalovirus. It could be a lot of other diseases and not just ROP. So one step back to re-study the patient is a good idea in these cases. And as well as Şengül said, in cycling, we do a lot of vocals in patients that were or not were treated that has that they have abnormalities in the periphery. It could be with laser, it could be with anti-angiogenics, or it could be that they will never been treated. But this area where there was a demarcation line is an abnormal area of vitreoretinal fixation, and as the eye enlarges, it could develop a retinal detachment with any treatment or even without treatment. So making vocals is a good idea in many of these patients. But first, study your patient. Usually with a good treatment, they will regress very well, and you don't have to retreat many times. And I see an over retreatment just because they see the tortuous vessels, and they are usually because of pulmonary bronchodysplasia or other pathologies.
Anemia.
Yeah, systemic conditions are really very important. And one of the audience were asking about how much do we wait for plus, or do we wait? We should check the systemic condition. And if there's only plus disease, if there's no stage 1, 2, 3, or if you don't, if it's not in the zone 1, then just check. If it doesn't fulfill the criteria of type 1 pre-threshold, you just follow, even if you have plus disease. And you just check the, systemic condition. If the, baby is having, for example, intestinal surgery or intracranial something, and then it may go, in a bad way. Then when the systemic condition is getting better, then it will regress spontaneously in some of the conditions. That's what Mariana is emphasizing, I guess. We have some other questions. One is about the crunch phenomenon. Did you have any case like that with crunch phenomenon, my friends? I have a case. No, it was referred to me.
I had what it can be some kind of crunch disease. I don't have much crunch diseases because I don't inject in a phase where you have a huge retinal proliferation already in a phase of fibrosis. And in zone 1, where you have already a lot of fibrosis, I mean, when it's not yet a stage 4, but you know that it's almost, you can see the traction, you can see the vectors to close around the optic disc. In that case, I go 2 days after to DOR. But if you don't go 2 days after to DOR, you see a bleb retinal detachment, a mushroom. And so that was the only crunch disease I had because I injected the baby. The baby was sick and I just could make the surgery, 10 days after. So then I had no way how to guide this kind of disease because I induced a crunch disease because I injected an aggressive ROP and I could not make the surgery because it was a very, after the time, it was not a sniper shot. It's always the same problem. It's not the sniper shot. If you inject after what the ideal time, you can have the crunch disease. If you inject at stage 4, you can have a crunch disease. So you must be very careful to inject outside the usual, the real perfect time to inject. So we are snipers. And I just had that crunch disease, and it was very difficult to solve, but I solved it. But it was quite difficult. And you have no guidance. You don't have the rules how to address this kind of detachment.
The main
So
thing
it's
is
rare.
the
It's a
timing.
rare.
Main thing is the timing. So if you inject the anti-VEGF during the high VEGF level period, then it works. But if you inject the anti-VEGF during the lowered VEGF time, where the TGF-beta is the prominent one, when you give the anti-VEGF, then TGF-beta will be more prominent and it will cause more fibrosis and traction. That's the main thing. So you shouldn't inject in late cases. You shouldn't inject after 40, 42 weeks or something like that. So in those cases, usually fibrosis is the more prominent part. Yes, please, Marianne.
What we see also, and we see it a lot, is that they try to rescue the eye with laser once the retina is starting to detach. And laser, as well as the anti-angiogenic, they have these proteoglycans and they move all the vitreous and it crunches. So laser or anti-angiogenics are not a good idea once the vitreous is involved. There is a very precise time for the treatment with anti-angiogenics, laser, both, no cryo. And there is a very precise time to do surgery.
Maybe I can.
In early stages, they go very, very, very well. So don't deny the baby the option to have a surgery trying to rescue something that is already bad.
Yes, but I have to open maybe a parenthesis for that. If the baby is stage 4A, and if you want to send it, refer it for the surgery, but if there will be some delay for the surgery, then during that period, it may be a good idea to do laser to the periphery, if it is possible. You know, if you are the one who will do the surgery, of course, you will go directly to vitrectomy. But if it will take some time for the baby to go to the surgical center, maybe to do some laser to fixate the periphery may be a good idea, just to have some time till a few days till the surgery. Yes, please.
Also the timing of the injection before surgery, because sometimes they do the injection in
not injection.
And they struggle with the baby. Please don't, because they say, "I will inject you meanwhile you get to surgery." No, even when I do injections before surgery in patients that they arrive just to surgery, even in 4 hours you can still see some crunching.
Yes.
So if you're going to inject a baby, you need to know the time, the place where it's going to be the surgery, that the team is already, everybody is ready. You have to have everything in the logistics of doing the surgery when you do that injection. You just not inject and send it. No, you have to have everything set up to receive that baby in the OR to have a surgery. If not, it's better not to do the injection. It's better to leave that.
Another question is about reactivation. What if you want to inject after the reactivation, second anti-VEGF, what time duration after first injection? Do you inject for 6 weeks or should you wait more for the second injection? Would you like to answer these?
Well, if we have reactivation or recurrent disease, if we have a recurrent disease, so an early reactivation, you must be sure it is really reactivation. I mean, if it is next week or 2 weeks after, you must check the baby again, because perhaps it's not ROP, or if you check all the conditions of the baby and really it is ROP. So if you don't have a normal answer to the injection, you must see if it is really ROP, how are the systemic conditions, and perhaps if the injection was properly done. I mean, if there was a proper injection of anti-VEGF in the eye. But usually you must, the re-injection or the recurrent disease is not 2 weeks after the injection. Usually it's 4 weeks, 5 weeks, 8 weeks. For instance, in Avastin, it depends on the drug. But if it is an early recurrent disease, you must see these issues. If it was properly injected, I mean, if there was injection inside the eye, drug inside the eye, the systemic conditions, because it may be not, and if it is or not ROP. So I think, Mariana, you agree with me about this?
I agree perfectly. And one is reactivation, another
and
is
the other one is
and another is a failure to treatment. If there is a failure to treatment, that is not ROP, or your needle was empty. That is what Susanna was saying. The amount of the anti-angiogenics is so small that sometimes it stays in the needle, and it's not really rare that we see this. That they did an injection and nothing happened. The thing is that everything stayed in the needle. You have to see a
Be sure that you don't have air, that you put on, not down.
Up.
So be aware if you have this kind of early recurrent disease. Yes, Marianne.
Because usually the injection works very well in every patient. When it's not happening like that, or this is not the disease, or the technique was not well done. You can check the SAFER paper.
Yes.
SAFER, and there is a technique for the injection.
And there is a very interesting question about what's the lowest gestational age to inject anti-VEGF? So, and I answered, I never have this kind of problem. I mean, as soon as I see you have a type 1 pretextual ROP, I do the treatment. I mean, if you have the screening and during the screening you see a type 1 ROP, you inject. 28 weeks postmenstrual age, that means that it's a very, very, very tiny baby. I mean, 23 weeks of age. And perhaps at 20 weeks, it can be a type 1 disease. Why not to inject? So I think, in my experience, I don't have a lowest limit for injection. I think we must make the treatment that the baby needs. Now, you must be sure it is an ROP, it is not another kind of problem, yes. But if you check the systemics, if you check everything, and really it's an ROP at 28 weeks postmenstrual age, why not make the treatment? Who agree with me?
Okay. So another question by Umesh. He's asking what are the indications for lens-sparing vitrectomy in stage 4A versus 4B? Actually, we always try to do lens-sparing vitrectomy. In stage 4 cases, if the retina is not too much direct to the periphery, if it's not attached to the back of the lens, we try to do just lens-sparing vitrectomy. We try to avoid from the direct part also, maybe do just nasal approach if it is in the temporal part, and try to preserve the lens. But I can say that in most of the stage 4A cases, it's possible to do lens-sparing vitrectomy. And in stage 4B cases, it depends. If it's totally direct towards the back of the lens, and if you don't find any place to enter the eye safely through the pars plicata, then you may need to do lensectomy, vitrectomy. But always try to find a place to spare the lens. Do you agree, my dear?
What my dear teacher Hugo Quiroz said once, the only thing that works in ROP is the lens. So if you can preserve the lens, preserve it.
Yes. I definitely agree.
Completely agree.
Subhadra has written that she couldn't participate due to some sound issue in her phone. Sorry for that, Subhadra. We missed you. You're welcome. So another question is, Actually, Mariana, you have answered that. Do you inject anti-VEGF before or at the end of ROP surgery, and for which eyes? I think we can say that we inject anti-VEGF before the surgery only if it is very vascularly active. Just I do just 1 day before the surgery, not more than that. If you do it much earlier, like 2, 3, 1 week, and then you will have very bad crunch. And at the end of the surgery, again, I do it rarely, but I do when if the disease is in the zone 1, and when even if you have, done the surgery very nicely, you don't want to do the laser to the whole avascular retina, which is extending towards the zone 1. Then what I do is I do laser to zone 2 and 3 and leave the zone 1 without laser, and I inject anti-VEGF at the end of the surgery just to preserve that avascular retina, to give the chance to do that. And we have actually collected our data, but not published yet. AJ, my previous fellow, has asked this. Thank you for the question. And do you have any addition for that?
Yes, also after the surgery, sometimes as there is a saline it washes a lot the anti-VEGF. So sometimes we don't really leave it. And laser, we delay the laser as well as Şengül. We delay the laser a lot, even after 6 months, when we already gave all the time to that baby to have the vessels grow toward the periphery. But it takes us a lot of time to decide to put laser when there is not another complication, just because we're having persistent vascular zones in the periphery, and it's a large persistent vascular zone. If it's a small one, we don't do laser.
Well, after surgery, 2 diameters is normal. It's not a vascular part,
yes,
so today is normal. But after the surgery, I almost never use anti-VEGF. I do laser for all the vascular area, spare the zone 1 area. But as Mariana said, we can clean the inside of the eye, and you don't have enough retina to produce, because you lasered, to produce that anti-VEGF. What about the laser of the peripheral vascular areas? Well, I quite have a study for 6 years now, so I still didn't decide completely. So the aim of treating ROP is to preserve retina. So the problem is, shall we preserve safely or not safely the retina? I have peripheral vascular areas, huge peripheral vascular areas with angiography, no kind of activity in angiography, and I preserve those vascular areas. And there are a lot of them. So a percentage of laser that I have to do to vascular areas because they have some kind of activity in the periphery. And I say the children that were treated with anti-VEGF or type 2 ROP, I have just 25% of them treated with laser, and those were because they had some kind of activity in the interface of a vascular and vascular area. Of course, the other, I am following them up, and they don't have until now any kind of recurrence. Now, it is a burden to see those babies. It is a burden to make general anesthesia and to make correct observations and angiography, but we can learn a lot about doing for systematic ablation of the periphery or just selective ablation of the periphery. So I think we have a lot to study and to decide what to do to those vascular areas, because even if you do laser, you can have late retinal detachment in the interface of the laser. So you cannot sit quietly even if you have done laser to the baby. That's my opinion. Mariana.
There is no consensus, nor an international consensus, is what are we going to do with these peripheral avascular zones. There is not a good thing or a bad thing to do. Is it we do a lot of just observation of these areas. We in some patients do laser, but there is not an international consensus. So
It's not yet.
Both are the right answer. Do laser or not doing laser, because both are the right answer. But in both, you have to stick to the baby and be screening them all the time, because
All the time.
False idea that if I do laser, I don't have to do the screening anymore, and they can go to
And it's safe. The baby is safe.
And no, there are not safe babies with this. They have to come and do the screening if they had any kind of treatment, and there is not an international consensus. So both screening, doing laser or observation, I think that both are right in the right patients, in the right hands.
I think it's time to stop because we have, we are quite,
Work.
yeah, you have work
Me
and
too.
quite finished.
I've got to work.
It needs to be finished half an hour earlier. Thank you. And Paras and Sharia, would you like to add anything?
Thank you, ma'am. Thank you, ma'am. Thank you so much for sparing time and connecting with all of us. It is always enlightening for people and physicians all around the world to gather and discuss about a topic. It's very informative. Thanks a lot, ma'am, for spending so much of time with us. We really loved it, ma'am.
Thank you so
Thank
much.
you.
Okay.
Thank you,
Thank
Dr.
you.
Sujata, ma'am. Thank you, Mariana, ma'am.
Have a good
Have a good
day.
day.
Bye-bye.
Have a good day. Bye-bye. Thank you.
Thank you very much. Thank you. Bye bye.